It's cataractcoach.com when we have a guest surgeon, Dr. Mohammed Ghoneem, who's showing us a very difficult case that's handled in quite an expert manner. There's a small pupil case. You can see the iris prolapse. You can see a dense white cataract. There's some trypan blues being instilled inside the eye to help stain the lens capsule. Looks like some anesthetic going in the eye now. And again, iris wants to prolapse here. You also notice this patient has a peripheral iridotomy as well as a trabeculectomy. So here, as the viscoelastic is pushed in the eye, look how much posterior pressure there is. So the answer here is not to push in more viscoelastic. You don't want to have that pressure gradient. So instead, Dr. Ghoneem is going to put in iris hooks, and that's a great option here. So making the paracenteses incisions for the iris hooks. The iris hooks are going to pull the iris out of the way and give us a lot more working room. You can see the very central part of the capsule was stained by the blue dye. Sometimes in these smaller pupils, it's helpful to put a little bit of the trypan blue dye, just a few drops, under the iris, and then use the cannula to spread that out. That ensures a more even staining of the capsule. So here we go. We've got now 2 iris hooks, which is helpful. Still a very shallow anterior chamber. And so now capsulorhexis is being started with the forceps, using the forceps to enter and pierce the anterior lens capsule. Now the careful part here is don't make too small of a rhexis. It'll make the whole surgery much more challenging. You want to have a normal-sized capsulorhexis, which is sometimes difficult with a small pupil like this. That's a reasonable capsulorhexis. I think it looks pretty good. I tend to favor a little bit bigger. So more viscoelastic going inside the eye now. Now, what are the other options? You could put in more iris hooks. Now, when you do hydrodissection here, there's likely to be, again, like there, more iris prolapse. Because you're adding more fluid, more volume inside the eye. So it causes more of a pressure gradient, and you get the iris prolapsing again. So again, we can put more viscoelastic, but again, more iris prolapse. So this is the kind of the catch that you get into. You could put in 2 more iris hooks now, or you could just proceed with phaco. So let's see, Dr. Ghoneem is going to go just to phaco. And so he's got a chopper in the left hand. Let's see the technique here. And cleaning up the anterior lens material to improve the view. And that looks great. So now the technique's going to be, let's see, is it a groove down the center? So maybe a stop and chop technique or a divide and conquer. So making that first groove, we can speed up the video here a little bit to get through the case. So there's the groove. May need to use more phaco energy. We don't want to see that nucleus moving too much. Chopper going inside the eye. And then the lens nucleus can be cracked into 2 halves. That looks good. And then each half is grooved again. So we'll go to divide and conquer technique, another little groove. And then split that first half into 2 quadrants. Each quadrant can then be removed. So now rotating again for the last piece. Now there's no phaco chop technique going on here, and that's okay. It depends on what you're comfortable with in your hands. So divide and conquer can certainly be done here, stop and chop, or any variation of phaco chop. That's really surgeon's preference. The one advantage of doing a divide and conquer or stop and chop is the grooves actually debulk the central dense endonucleus. So if you just chop the nucleus in half, you have 2 halves, each one, let's say 50%. But if you make a groove down the middle, that groove has a width, and that takes away some of the volume of the nucleus. So then the 2 halves that are remaining may be 45 and 45%, because 10% of the lens nucleus bulk was removed in just making the groove. And therefore these 2 halves that we say that we have in divide and conquer or stop and chop may actually be smaller than the halves that we have when we just do a phaco quick chop. So removing the lens nucleus, nice and easy. On this setting here, you definitely want to have a very high infusion pressure. So if you're using a machine with a bottle height, that means get that bottle height up very high. If you're using a machine that has forced infusion, either with pressure plates or with gas infusion, you want to set the infusion pressure relatively high. And that's going to help counteract some of the posterior pressure by having a high infusion pressure that pushes the opposite direction. Here's the last piece of the nucleus coming out, using the chopper just to push it in front of the probe. And that looks pretty good. So I'll speed up here a little bit more. I'm going to do a bimanual irrigation aspiration. And so bimanual is very helpful in this type of eye because it's going to give you very good access, sometimes a little bit better access than you could get with just a coaxial probe. So cleaning up about half of the cortex this way, and then of course the hands can be switched to go in the opposite direction. Another important reason why ophthalmic surgeons really need to develop, really must develop good bimanual dexterity. You should be able to switch hands relatively easily. And so again, finishing up the cortex removal with the IA. And of course, our last step here is going to be to put in the IOL. There you can see the outline of the capsulorhexis, very reasonable in size. Again, I tend to prefer a little bit bigger just to make life easier. There's the fill with viscoelastic. And then hooks coming out now. I actually would leave the hooks in until after the IOL is inserted, because that'll give you a better view. You can see the edge of the rexus a little bit better and make sure that the lens is going in to the capsular bag completely. And so now comes our lens. Going to put in this lens, of course, in the capsular bag. Fixating the eye. Here comes the lens going right in and dialing it completely within the capsular bag. That looks great. Looks like a single piece lens. And then another smart move here. Very helpful to put a suture in here. There are a couple reasons. One, the incision's fine. It's very well constructed. That's not the issue. But the reason is, number one, there was a lot of iris prolapse during this case. So putting an incision, suture in the incision is helpful to make sure there's no prolapse in the post-op period. That angle sweep there is to make sure there's no iris trapped in the incision. And now it can be sutured down. Second reason is, remember, this patient has a trabeculectomy. The trabeculectomy, when it works, is going to lower the eye pressure. And sometimes the pressure can be so low that it doesn't allow the incision to stay sealed well. So putting in a suture here is highly recommended and is a very smart move by Dr. Ghoneem. And there's the end of the case. So beautiful case, and we thank him for sharing this with us. And please submit your videos to cataractcoach.com. Thank you for watching.